Hi there, everybody. Welcome to the webinar about CDC's PrEP Clinical Practice Guidelines. We'll get started in a minute or two as people enter the webinar room. So I hope you're having a great day. We'll get started very soon. Welcome, everybody. We'll give it another minute or so before we get launched. So thank you for joining this CDC's PrEP Clinical Practice Guideline webinar. We will be starting in about a minute. All right, it is 1:02 Eastern Standard according to my watch. So we will get started. I want to thank you all for joining this webinar entitled CDC's PrEP Clinical Practice Guideline and Strategies for Ending the HIV Epidemic in the United States. My name is Demetre Daskalakis. I'm the Director of the Division of HIV Prevention, and I'm joined with Dawn Smith, who will be my co-presenter and who is also lead author on the guideline. In December 2021, CDC updated some sections of the Pre-Exposure Prophylaxis Clinical Practice Guidelines. The updated guideline provides physicians and other providers the latest science and information to really effectively prescribe all types of PrEP to their patients for HIV prevention and also increase PrEP use among folks who could benefit. It's important to note that there are some sections that didn't change. There are no changes to the populations for whom PrEP is recommended or to the recommended daily dosing regimens for oral PrEP. Also, there are no changes to the frequency of HIV and STI testing for daily oral PrEP. So the revisions are intended to update existing guidance using the current evidence base that we have, incorporating recent and anticipated FDA approvals for PrEP medications. So that specifically refers to Kabategravir, and to clarify specific aspects of clinical care and to improve usability and also increase implementation of the guideline. Today, we're going to walk through the specific updates, and there will be time for questions at the end of our presentation. Now, one quick thing about the questions. We are not using the chat for questions. It is not actually enabled. We would love for you to put your questions under the Q&A tab, because that's where we're going to be monitoring the questions and answers so that we can make sure that we get through as many as we can in the time that we have. So with that, I will launch into the agenda for this meeting. So we're going to cover status of HIV in the United States. We're going to then cover ending the HIV epidemic and really the role of PrEP, as well as some of the challenges that we have to be able to really fully realize and implement PrEP in the US. Dr. Smith will then take over and talk about the PrEP guideline, and we're going to share some duty talking about future opportunities as well as resources. So as promised in the agenda, we're going to start first talking a bit about the status of HIV in the United States. So in 2019, there were approximately 34,800 new diagnoses in the United States. You'll see by that downward arrow that there's been a lot of success in decreasing HIV incidence over time. Now, that just refers to the last four or 5 years, but thinking about the course of the entire epidemic, a huge decrease in new infections has been realized by the interventions that we had. So which really in effect means testing and treatment before PrEP really entered the scene. So HIV in the US continues, however, to be a disease characterized by disparities, and a lot of them are longstanding and follow really according to sexual orientation, race, ethnicity, and geography. In fact, the disparities we see in HIV are actually in the footprint of racism, sexism, homophobia, and transphobia, and the effect it has on all health scenarios in the US. So we know that there are 1.2 million people in the US who have HIV, and we know that health disparities persist. If you were just to take a quick snapshot, there are disparities that impact gay and bisexual men, Black, African American persons, as well as Latino people. They have a higher HIV incidence. There's gaps in PrEP coverage among Black and Latino people. There are lower rates of viral load suppression among American, Indian, Alaska Native persons, as well as Black Americans, and also a higher prevalence of HIV among men who have sex with men and transgender women. Additionally, although most of the outbreaks that we see in the US are in sexual networks, we are seeing increasing number of outbreaks among people who inject drugs, threatening a lot of progress that's been made in the community of individuals who use injection supplies. Now, it's not just a specific population, it's also geographic. So looking at this map on the right, you can see that the rates of diagnosis of HIV infection are highest in the South. In fact, in 2019, more than 50% of all new HIV diagnoses occurred there. So if it's hard to see the legend, really the colors, what you can focus on, the sort of lighter blues and really are areas with lower rates, higher rates are darker. So you can take a look at that. Really, again, really clear demonstration of disparity. Now, one of the important equity interventions that we have at CDC and in the US is the Ending the HIV Epidemic initiative. So I'll tell you, everything that we do is focused on ending the HIV epidemic. But the initiative specifically hyper-resources areas that have significant prevalence of HIV. It is a classic equity intervention from the perspective of adding resources where there is really significant need following what we see with the epidemiology of the epidemic. So there are 4 pillars that are both the core strategies of DHP, but also the Ending the HIV initiative pillars that we are all working to optimize and to accelerate to achieve a tighter control of the HIV epidemic, in effect, the end of it. So the first is to diagnose people with HIV as early as possible. The second is treatment, and doing that rapidly and effectively so we can really improve people's quality of life, as well as attaining viral suppression, which has amazing prevention properties as well, from the perspective of preventing forward transmission. There's PrEP, which we're going to be talking about today. When we say PrEP, we often then also talk about syringe service programs, since that's also a really important structural and biologic intervention that prevents HIV transmission. Although again, today we're focusing on pre-exposure prophylaxis. And then finally, respond, which is really identifying clusters of HIV and seeing that rapid transmission as a sign of failure for where we have problems with our either healthcare or prevention system where people are falling through cracks. So identifying the problem allows us to identify strategies to both address outbreaks for the people who are experiencing the outbreak, but also for leaving the system a better place than where we found it. And all of the tools, testing, treatment, and prevention, get pulled into the respond pillar to really customize what happens on the ground. Now, again, I think that I've impressed upon you that despite a lot of progress toward ending HIV, HIV continues to affect some groups severely and disproportionately. As we talked about on the prior slide with the map, rates of new HIV infections among Black people are over 8 times as high, and among Hispanic Latino people, almost 4 times as high as the rate that experienced among white people. So to end the HIV epidemic, we really need to focus on equity. We need to scale up HIV testing, make sure people with HIV are linked to care and getting treatment, and ensure equitable access to HIV prevention, and that includes PrEP for everybody who could benefit. I will show you this graph and as an example of data that demonstrates how current PrEP coverage remains uneven across racial and ethnic groups. It also is uneven among age groups and also among gender identities. So the disparity, however, when you look at this, so again, the red line are white individuals with indications for PrEP, and the percentage demonstrates how many of them are actually getting it. The disparity is increasing between white persons and Black and Hispanic and Latino persons. Remember, Black and Hispanic Latino people account for the majority of people for whom PrEP is recommended, but they have the lowest rates of PrEP use among all racial and ethnic groups. Data from CDC show only 8% of the nearly 469,000 Black people who could benefit from PrEP have received a prescription in 2020, and only 15% of the nearly 313,000 Hispanic or Latino people who could benefit from PrEP have received a prescription. So our nation will only realize the promise of PrEP if we can have access for all the populations that need it in an equitable fashion so that they can use it to prevent HIV. I'll also tell you that PrEP coverage is also unevenly distributed among people based on sex. And this is specifically sex of birth. Among people for whom PrEP is recommended, PrEP coverage was about 3 times as high in 2020 among males as it was among females. Cisgender women represented 19% of new HIV diagnoses in 2019. So that's really, again, like there's a disequilibrium in who is getting diagnosed with HIV and who is getting PrEP. So we need to do better to really try to address the equity issues and coverage and access across the populations. So addressing the imbalance is critical to achieving adequate PrEP coverage for us to be able to reach that spot where we can say that we've ended the epidemic. Again, I'll remind you that we plan on significant investments at the federal and jurisdictional level to increase PrEP access, uptake, and persistence. It's one of our no-fail missions. Only 10% of people who could benefit from PrEP were prescribed it in 2020. Only 27% of Black, 31% of Hispanic Latino, and 42% of white, gay, and bisexual men who in a survey by CDC who could have benefited from PrEP used it in 2017. And then among transgender women who were HIV negative, 92% had heard of PrEP, but only 32%, which by the way, 32% is impressive, but not impressive enough, had used it in the last 12 months. So definitely work to do. And this is survey data that is another view that supplements the data that we have from prescribing data, which is what I shared previously with the graphs. So one strategy to address this is our status neutral approach. And that status neutral approach to care means that regardless of HIV status, people have access and support to stay on highly effective public health interventions like PrEP and HIV treatment. When people are supported to fully utilize these interventions, the outcome is the same. HIV infections are prevented. So really, by offering HIV services alongside other local healthcare and social support services used by the community, HIV prevention and treatment become a part of the fabric of holistic care designed to meet the needs of each person. The time is now for PrEP to be a part of the general care of the population, and we're going to talk a lot more about that. As a person's needs evolve, they can be seamlessly connected to new services. The outcome is not only improved HIV care, but better overall health and social stability for every individual so that they actually have the ability to pay attention to that area of their life that really is around HIV treatment and prevention. So the real idea of the status neutral model is that the HIV test opens a gate. It allows people to think about HIV treatment and prevention. And if supported properly with culturally inclusive, responsive quality care and the interventions that address a lot of the social determinants of health that are so often the barrier to treatment and care, they stay engaged in a treatment and prevention pathway. The goal is engagement. So by coming into this system, you engage in treatment, and by being engaged, the right thing tends to happen, which is people follow guidelines, folks go on meds, and their viral load becomes suppressed, quality of life is better, and they don't transmit HIV. Prevention pathway, very similar. If the HIV test is negative, it's an opportunity to talk about PrEP and to really think about it and engage people in a prevention pathway that brings them into a strategy that could potentially mean PrEP. It may not mean PrEP on day one. It may require more conversations, but ultimately that engagement leads to powerful HIV prevention. It also, when you really look at the way that our service delivery system is built, parallel services and structures historically that have been created for people with HIV or those who could benefit from prevention ends up impeding efficient use of resources. So really striving toward a more status neutral environment to deliver service where it's not about your HIV status, but what do we need to do to keep you engaged in either prevention or treatment so that we can really optimize your health. And in that optimization, get you on medicines for HIV if you need them, or on prevention medicines if you need them. So either way, one door or every door leads to the same place, which is optimal health, regardless of the HIV status. Now, the reason that this is possible is not just PrEP. So that part of the engagement that focuses on treatment is really fueled by the fact that a person with HIV who takes medicines as prescribed and gets and stays virally suppressed or undetectable can stay healthy, their quality of life improves, their viral load is suppressed, their disease does not progress, and also there's effectively no risk of them transmitting HIV to their HIV negative partners. So with PrEP and treatment, you put it together and you have a recipe to create a system that delivers care for the whole person and also really strives toward the end of the HIV epidemic in the United States. So another really important factor there is that when you think about that status neutral strategy of service delivery, it really requires people to think in a syndemic way. So what is a syndemic? Let's start with that one. A syndemic is a set of linked health problems that interact with each other in an environment of social injustice and results in an increase in the amount of severity of disease in a population. So either the amount of disease or its severity. So when we think about syndemics, systemic racism, sexism, homophobia, transphobia, and a multitude of other social determinants like unemployment, inadequate housing, potentiate these interactions to worsen the adverse effects of these interacting epidemics on community health. So I'm going to just give sort of a framework of how I think about it a little bit. When I was training in infectious diseases, one of my senior mentors taught me a Latin term, and some of you may have heard this, called Locus, Minoris, Resistancia. It's the idea that an injury can make a body area or a part more susceptible to another and potentially worse injury. So as an example, if you twist your ankle, that ankle is going to be more likely to be twisted again or potentially hurt even worse. So I really think of it the same way. Our communities have been injured by centuries of bias and invisibilization. The long-standing injuries created by these isms, phobias, and the systems that maintain them allow for multiple epidemics like HIV, STI, viral hepatitis, COVID, tuberculosis, and many others to interact and billow up to a syndemic, leading to worse health outcomes. So though PrEP is not the only thing, we need to think about it in the context of what we can do to interrupt the cycle of injury upon injury so that we can better control the syndemics. And I think we have a lot of strategies from the perspective of what that could look like. So it's really thinking about people, thinking about place, thinking about science and what we know and how to implement it quickly, but then also to think about policy. So we do the work because people matter. And again, disparities will form in an unjust society, and we've seen that for years, and it's been amplified, and we've been reminded again in the COVID-19 space. But it's important to remember that the disparities are inevitable. So if we really focus on people and a holistic approach that really identifies their social context and then strive for health equity, we are going to make a change. So it really is about thinking about what can we do to address the disparity? What can we do to create that equality, that equity that you're seeing in that little graphic that shows the folks on the steps? Part of that is also focusing our resources on where the epidemic is, and ending the HIV epidemic is a great example of this. So it's really hyper-resourcing areas to make sure that we can accelerate the end of epidemics in populations who are made most vulnerable because of the systems that they've experienced. We can't just do that by a program. It needs to also be thinking about public policy as a really important public health tool and identifying levers that we can switch to be able to address the system issues that interfere with our ability to deliver innovative work. And then finally, speaking of innovation, there's a lot of innovation, and it's really important that it doesn't sit on the shelf. And that means thinking about implementation and the implementation strategies to accelerate things and interventions from a clinical study has shown it to actually changing the HIV epidemic and the other syndemics on the ground. With that, I'm going to hand the mic over to Dr. Smith, who is going to go over a bit in detail of our guideline, what's new, what's not so new, and then we'll make sure that we have time at the end for questions. Dawn, I'm going to hand you the virtual mic.
Hello, I'm happy to be here. Next slide. So as Demetre said, there were several things that were not changed from the 2017 guideline, for those of you who are familiar with that guideline. So we did not change what behaviors and clinical signs constitute indications for prescribing PrEP. We didn't change the frequency of follow-up visits for oral PrEP or the schedule for HIV and STI testing for oral PrEP. Next slide. Demetre? Okay. The first new recommendation in the guideline is that all sexually active adult and adolescent patients should receive information about PrEP. Doesn't mean they should all be prescribed PrEP, but they should all be receiving information. This isn't necessary, for example, at every visit, but it should be part of the kind of primary care plan for a patient. And we recommend this to encourage providers to offer PrEP as a core primary care service. And this will help us to reduce the missed opportunities for PrEP provision that we know are occurring and that are resulting in unnecessary HIV infections. It will also increase the knowledge of PrEP among potential users. One of the biggest barriers we find in community surveys is that many of the people who really have indications for PrEP have never heard of it, don't know what it is, and certainly don't know to ask for it from their provider. By having providers explain what PrEP is to all patients, it allows them to consider whether they want to consider using it now, maybe in the future, and it allows them to actually request their providers to prescribe it to them. The last important reason is that it increases the knowledge of PrEP in the community. That means that patients who learn about PrEP and who are themselves don't think that they're a candidate for PrEP may have a family member or a member of their social network for whom they think PrEP might be a good option. And it allows them to have the information to share with those people who they think might benefit. It also means that if people that they know begin PrEP, they are less subject to some of the inaccurate information in the community about PrEP and more capable of supporting PrEP use by the people that they know. Next slide. So one of the things that we did was respond to provider suggestions about how to make our guidelines more clear and more usable. And there was a strong preference for more tables and more figures and less text. This is the summary table that talks about how you prescribe oral PrEP. And I'm not going to go through it all in detail. I think there were a couple of changes from the 2017 guideline. So in the 2017 guideline, we recommended estimated creatinine clearance for all patients every 6 months. And now we only recommend that for people who are at highest risk of having renal changes resulting from tenofovir use. And so that is older patients and those who have a marginal estimated creatinine clearance when they start PrEP. All other patients can be assessed every 12 months. The other thing we did was we took out the pregnancy testing for women who are using oral PrEP, because it's now known that it is safe in pregnancy and in fact recommended in pregnancy for women with indications. Next slide. We also provided a section on prescribing what's called event-driven PrEP. So there are some MSM and transgender women who don't want to take a pill every day. They want to take pills to protect themselves as they have potential sexual exposures. And in a study looking at this strategy for MSM and transgender women, it was highly effective. And so even though it is not an FDA approved strategy, and so CDC is not recommending it as a primary strategy, because it's widely used in some locations, we did introduce a section that has just instructions for how to do it. And I will refer you to the guidelines for the details. Next slide. The other new thing in the guideline is the introduction of a new modality of PrEP, which involves injections of a medication called Kabategravir every 2 months. And so this was recently approved by the FDA in December of 2021 and is now being rolled out. This is indicated for all persons with indications for PrEP. And so we added instructions for how to initiate and follow up these patients in a table similar to what is in the oral PrEP table. I won't go through this in detail, except to say that it involves regular HIV testing to detect acute or incident infections, regular STI testing, and then advice on how to prescribe Kabategravir, how to provide Kabategravir injections. Next slide.
Thank you, Dawn. So in terms of future opportunities, one really important area that we are keen on working on is increasing PrEP providers. And so I think you can see from the presentation on the guideline the real sort of emphasis on this being a part of this sort of routine primary care for adolescents and adults in the United States. So really embedding it into primary care and embedding it into the routine care and those strategies, I think, is critical. There are a lot of reasons other than the urgent need to end HIV why this is the time to incorporate PrEP deeper into primary care. And some of them are really on the administrative side of the world, which include the U.S. Preventive Service Task Force assignment of a grade A recommendation for primary preventive care for PrEP, followed by the CMS FAQ that supports both the medications and the clinical services that support PrEP. They should be covered by insurance without out-of-pocket cost to the patient. So that means no copays. We also know that PrEP is a highly effective primary care intervention, really similar from the perspective of impact to many things that we do every day. But we need more providers to educate their patients about PrEP and prescribe it. So if there's one thing that we would love to have you all walk away from this meeting with is that PrEP is something that is in your hands, and that you should feel confident in prescribing. And if you have questions, use our guideline to support the work that you're doing. I want to give a little bit of a view into where we are and where we've been. So as of 2019, there were 66,000 PrEP prescribers. When compared to 2014, that is over six-fold increase. It was 9,600 in 2014. Of those 66,000, a little bit shy of 70% were physicians and 30% were NPs or PAs. 4% of all active providers had prescribed PrEP. That's 13% of family practitioners and 34% of ID physicians. So that's the first call to action. We can do better than 4%. And so I think shifting that number to double digits, and let's get it to 90, but we'll take double digits, really is critical from the perspective of upscale of PrEP. And I think that this statistic is really important to think about. When you look at patients who were prescribed PrEP, 50% of them were prescribed by 3% of PrEP providers. We know that other providers see people who could benefit from prevention. And so it's really critical to shift that 3%, to bump it up and have it be more a part of the normal primary care that we do every day, rather than something exotic and different than smoking cessation, counseling about diabetes and pre-diabetes, et cetera. This is really in the vein of the work that we already do in so many other parts of our primary care interventions. I think we have a lot of future opportunities for PrEP. We have PrEP delivery methods that are coming that are very exciting, potentially new venues that could potentially do PrEP. So thinking about pharmacy clinics, et cetera. We also need to evaluate PrEP choices, like really understanding now that we have a broader range of options for PrEP, like what providers like to do and what people who could benefit from PrEP would like to do as well. And also how they move between different modalities. So I think it's critical from the research perspective to understand that, so that we can better implement and identify strategies that actually increase demand for PrEP by really contextualizing it to what people want and need, as opposed to what we think that they need. Also, really exciting news is that the US Preventative Services Task Force is going to be reviewing injectable PrEP and other PrEP choices to see if their grade A could be potentially expanded. So they have to make that decision. They're going to have the conversation, but we're hopeful that that will expand the circle of what is a usable PrEP intervention that is also implementable in real world. I also wanted to briefly talk a little bit about resources. So many of you who are thinking about PrEP, sometimes it's good to know like where you can get the backup. So Guideline is a great place. I think Dawn told you about its simplification and your ability to use more visual graphics to sort of guide you in the work that you're doing. But I also wanted to highlight our HIV campaign, Let's Stop HIV Together. It's a status neutral treatment and prevention campaign that focuses on stigma, patient-centered care, testing, prevention, treatment, and care. It has consumer-facing materials as well as clinician-facing materials. So really good information there in terms of thinking and promoting PrEP. There are also a host of other resources for clinicians. One that I really want to emphasize is the PrEP line. That's 855-HIV-PrEP. It's toll-free. It's for clinical care questions around PrEP provision. So if you have a question about how to do it, or you hit a snag on the road and you want to talk to someone, this line is a really great place to reach out to. Also, the PrEP line is going to be able to assist people if they have ambiguous test results. And by people, I mean providers. So the provider can reach out and say, I have a positive this and a negative that. What does this mean? What do I do next? And is there a need for more niche testing? And they can assist with that. Also, we would love for you to call that number on the rare occasion where a person who is prescribed PrEP and is on it has acquired HIV. I also want to talk about a really great resource over at NASTAD. The web address is there. And again, later we're going to send these slides around. There's a billing and coding guide. Since so much of this implementation really depends on what it's like in your practice or in your venue's practice, this helps along the way. And I also want to remind people about HIV Nexus, which is our resources for clinicians. And it's a really great resource that is a one-stop hub to support clinicians in the work that they're doing in HIV. So it contains latest research and information on HIV prevention, screening, and treatment, and provides access to free continuing medical education programs. Also highlights guidelines such as this one, as well as other recommendations, and from that hub, you're able to really reach out to find those patient education materials that are so important in communicating the importance of PrEP. I also want to talk about ways to help patients pay for PrEP. So remember, because of the grade A recommendation from the Preventative Services Task Force and that sort of follow up by CMS Department of Labor for a no cost coverage rule, commercially insured patients should have no out-of-pocket costs for medication, clinical care, and lab tests. For uninsured people, one strategy is to get them insured, and healthcare.gov could allow them to access plans that they may be able to enroll in. But also remember that free medication is available for people through various strategies. One is the Ready Set Prep program, which is accessible at hiv.gov, as well as assisted programs that are run by the companies that produce the drugs approved for PrEP. Also, I want to highlight that our goal is to make sure that we provide the most flexibility for the folks that we provide funding to, our grantees, to use their CDC HIV prevention funding in a way that really helps them best help their community. And that includes PrEP ancillary services when needed. So our Ending the HIV Epidemic funding source actually provides for coverage for these ancillary services. And at the end of last year, we looked at our flagship health department funding opportunity, also called 1802, but just think about it as a health department flagship, to allow them to actually use 15% of their funds towards lab costs, navigation, mobile units, all the ancillary services. Now, it doesn't cover the purchase of PrEPnet. It is sort of supplementing some of the options that I talked about, like Ready Set Prep, with support for some of the ancillary services that might not be covered for some people who are uninsured. So I also want to emphasize that we don't have a vaccine and we don't have a cure, but we still have a really unprecedented opportunity to end America's HIV epidemic with really potent prevention and potent treatment that both improves people's health and prevents HIV while addressing care and other strategies that improve quality of life. We can really move the needle and get to that place by 2030 where we can say that we've ended the epidemic of HIV as we support people living with HIV through, so we can maintain that end. With that, I will shift over to questions. And I know that we do have some that are in the Q&A section. So I will look over there. So I'll start with the first one that I see, which is for patients opting to switch from oral daily PrEP to injectable PrEP and want to forego the oral lead-in of Kabategravir. Does the CDC have any recommendations on continuing oral PrEP after the first injection? Current CAB data does not have an indication of protection levels other than after 1 month of the oral lead-in. I think Dawn would like to take that question. Dawn, feel free to unmute and answer.
Sure. CDC does not recommend any continuation of oral PrEP after initiating injectable PrEP. You'll notice in the trials after the oral lead-in, there was no overlap between the oral PrEP and the injectable PrEP. People moved immediately to injectable PrEP, and this is what we recommend currently.
Thank you, Dr. Smith. I see a question. How have HIV rates among people assigned female at birth changed? So I'll just briefly say you should please visit the epidemiologic, the surveillance report section of our website. We can put that, we'll make sure that we make sure that you know where that is. You can actually see trends over many years. Again, you'll see that there's been a significant decrease. I think that one of the notable observations is that the disparities that we see in HIV sort of are pretty clear among women as well. So with rates of HIV decreasing quicker among white women than other women of color. So I think, again, though I will refer you to the surveillance reports to see more detail. I think that that really women, people assigned female at birth, are experiencing the same disparities that I referred to in one of the earlier slides. Let's see. I acknowledge recommendation of Q3-month HIV test. However, with increasing telehealth appointments during the pandemic, we have seen the number of patients delinquent on labs skyrocket. Would the recommendation be to withhold PrEP until those labs are completed, or at what point would you recommend that, Dr. Smith?
I actually want to combine this answer with a question below about pharmacists prescribing PrEP and how to get testing in labs in that situation. Can you, Demetre, can you go back to the table for Kabategravir?
Yes, I can.
Okay.
Here we go.
So for oral PrEP, we have long recommended that HIV antigen antibody tests preferentially be used for initiating and for follow-up of PrEP patients, ideally in a laboratory setting, so by a blood draw, because these are the most sensitive tests to diagnose acute infection, and we don't want to start people on PrEP if they have unrecognized HIV infection already. But when it comes to the issue of Kabategravir, things have changed even beyond that. So in the studies that proved the effectiveness of Kabategravir for both men and women, they had a procedure where patients were tested locally with a laboratory-based antigen antibody test. And then when they tested positive, they went back to specimens that had been stored at each previous visit in a research lab to look to see what was the earliest time that they could detect actual virus. And what they found was that there was a delay in detection of HIV infections, even using the laboratory-based antigen antibody test. The delay was much longer for Kabategravir than it was for oral PrEP, for tenofovir-based oral PrEP. For the oral PrEP, there was a delay of about a month on average, although it could be longer for some patients. In the Kabategravir arm, it was more like 90 days of delay and could go out almost a year in terms of detection. For that reason, in the oral PrEP guideline, we say that for initiation, you can use the antigen antibody test, but for ongoing monitoring, it's really ideal to use a qualitative HIV-1 RNA. And for the Kabategravir, because it is in the body for up to a year after you stop it, so it's very long lasting, because the drug exposure is going to continue, we recommend qualitative HIV-1 RNA both for initiation and for follow-up visits every 2 months. Now, in the case of either telemedicine or pharmacy-based PrEP, the guidelines have some instructions about the use of telemedicine. And I think what we recommend generally is that there are a number of ways of dealing with the STI and HIV testing when you're in these non-clinic based settings. One is there are companies that have validated these tests on specimens that are collected by the patient and then mailed to the laboratory for testing. And so that is one option. Now, the FDA has not yet approved those specimen collection kits, but they are not, they are in discussions with the companies and with CDC about how to get to a place where they are fully validated for the FDA. In the interim, they are allowing them to continue to be used. So that's one option. The other option, which came up a lot during the closures related to COVID, is that patients can report to a laboratory, a LabCorp, a Quest, to have specimens collected there and then reported to the provider. The basic principle is that patients who are on antiretrovirals for PrEP need to have regular HIV testing. This is especially important for those who are taking daily oral PrEP because there are higher rates of incident infections in that group than there are in the Kabategravir group. But it's also important for the Kabategravir group because of the long duration of the medication. And you don't want to be taking a person who has an incident infection and giving them substandard treatment, which would be a PrEP regimen. You want to convert them quickly to a fully effective antiretroviral treatment regimen. Demetre talked a little bit about the PrEP line. One of the things that has happened with Kabategravir as well as with Truvada is that because the use of the antiretrovirals can affect the speed and amount of development of antibodies and the rate of viral load increase in patients who become infected while they're continuing to receive antiretrovirals, you can get very kind of unusual test results. So you can get patients, for example, who have a positive antibody level and a negative antigen, or you can get people who have a positive antigen antibody test, but then a negative differentiation assay. So we're working with the PrEP line to provide advice to clinicians about how to do follow-up testing in these patients to determine their true HIV status and how to link providers to really advanced level testing if it's necessary to confirm HIV status. That's very important because we don't want to call somebody HIV infected who's not, for obvious reasons. And on the other hand, we don't want to call somebody HIV negative who is really in need of a treatment regimen. So that's a long answer to short questions.
Thanks, Dawn. That's a great answer. I'm gonna, the next question that I'm going to pose, and I think I'll pose to you is, oh, hold on for 1 second. So you all aren't seeing a blank screen. Sorry about that. There we go. Is, pull it up. If the patient misses their shot of Kabategravir and cannot come into the office, can we prescribe oral PrEP, and for how long?
Actually, the guidance, if you look at the package insert for Kabategravir for PrEP, the guidance is to provide them with oral Kabategravir, not oral FTDF. But yes, you can provide oral medication to bridge people who for some reason are unable to come into clinic for an injection.
Another question is a sort of specific example. We've been finding some insurances in New York still coming up with a copay for generic TDF FTC unless a PA is completed, so prior authorization is completed. Has there been any movement towards getting the PBMs to remove this requirement and just accept the ICD-10 code as sufficient documentation to pay entirely? This person also commented that it's resulting in delays to getting medication to patients. So I think the first sentence, I think the first statement is, it's important for us to know what the barriers are. So thank you for raising this. And Dawn, is there any movement from the perspective of PBMs removing the requirement and just accepting the ICD-10 code?
There are several community organizations that are working very hard on this, including an organization called PrEP for All, but there are a number of advocacy organizations that are working very hard to try to make this happen.
Great, thank you very much. So I think also we're working across government to make sure that things are implemented appropriately. So I think that we're also in the sort of just still honeymoon phase of this moving into standard practice. So I think that there are definitely going to be reports of things that aren't going exactly right. So I think it's really important for us to hear about them and to also have strategies based on what we hear to try to smooth it over so implementation goes more smoothly. So thanks for raising that, and thanks, Don. I'm going to take the next one. Does the CDC have a program to support PrEP access internationally, for example, in the Caribbean? So I'll just comment that the Division of HIV Prevention focuses domestically. So we specifically do not have a program to support PrEP access internationally, although our colleagues in global do work in HIV intently, and PrEP is definitely one of the important things that they focus on, although not specifically funding PrEP internationally.
And I would add that PEPFAR is a source of PrEP in many international settings.
Thank you. What options would you suggest to cover the cost of PrEP in instances where the free medication programs would not pick up the costs? So and there's an example. If we're working with a youth program and they're interested in PrEP, but not wanting their parents being made aware, programs such as Ready Set PrEP won't cover the meds because they, quote, technically have insurance. This creates a barrier that could be addressed if we could use a portion of funding to purchase the medication directly, as there are not great workarounds otherwise, especially given how changes have impacted the 340B environment and ability to generate revenue with the advent of generics. Dawn, do you want me to go first?
You say, are you taking that one?
Sure, I'll start. So I think that there's a lot of challenge. I think the adolescent example is specifically a challenge and requires some creativity. I think a lot of adolescent programs that focus on pre-exposure prophylaxis have really developed some strategies for workaround, including strategies that purchase generic PrEP, and sometimes that could be between, and Dawn, you can correct me, between $19 and $41 a month. So I think that as we have larger national discussions about really fully realizing a PrEP program, I think these are the considerations that are key in going forward. So I think this is a space to watch. Do you have anything to add, Dawn?
No.
Thank you. It is estimated that 20% of Asians living with HIV in the US do not know they have it. Many are diagnosed with AIDS due to delayed treatment. What is being planned for outreach to Asian communities about PrEP? So I'll first start by saying, please do look at our Let's Stop HIV Together program. I think it really focuses on strategies to reach diverse folks around PrEP treatment and HIV testing. Programmatically, I think that the focus that you're going to see in sort of status neutral service delivery and really embedding pre-exposure prophylaxis in sort of the routine service that we provide populations is important. There are a lot of great examples in the Ending the HIV Epidemic initiative. One example is that we've actually worked to get many sexually transmitted disease or sexual health clinics really doing PrEP and treatment where people seek care. So that's really outreach through providers and where people seek care, and are also doing similar work in other populations. So it is about generating demand, education, and using the resources that we have to promote, but also things like this, where I think when you raise sort of awareness in this space, remind people that the strategy to really offer PrEP or discuss PrEP in clinical encounters is critical to address the equity issues that hamper us. So I think take a look at our resources and the work that we're going to be doing in the status neutral space in different venues. Thank you. Can the patient take oral PrEP injection at the same time or switch? So I think that question means, can the person take oral PrEP as well as have a Kabategravir at the same time or switch? Dawn, do you want to take that one?
So not generally. There's no reason, if someone is on Kabategravir and receiving timely injections, there's no reason to take oral PrEP or post-exposure prophylaxis. Neither one of those are indicated in patients who are regularly getting Kabategravir. Certainly for all options for PrEP, patients have the choice of switching back and forth. So we know that many people, for example, try 211 PrEP and then switch to daily, and then maybe switch back to 211, and then maybe switch back to daily. We know that a lot of that is going on. In the case of Kabategravir, it's going to be a very different issue to be switching. And the reason for that is, as I said, when you stop your Kabategravir injections, it takes nearly a year for it to clear your system with men, and more than a year, slightly more than a year for women. And so figuring out when there's too little Kabategravir still in your body and you now need to switch to daily oral PrEP is a little bit complicated. And going back and forth between the two would be extremely complicated. So I think we're going to have to learn as we go how often patients want to switch and how to help patients switch safely.
Thanks, Dawn. There's a very specific question, which I think you can answer quickly, which is, can you clarify whether CAB is approved for the use in adolescents?
Yes, it is.
And can you comment on is there any age or weight recommendation that's tied to the approval?
Yeah, all of the PrEP recommendations are based on weight, not age. So any person, adult or adolescent, who weighs at least 35 kilograms, that's 77 pounds, can be started on PrEP.
Great, thank you. So again, no age, not an age cutoff, but a weight cutoff. So that's really important. I think we've answered this, but there's a question that says, I understood that it was not recommended to use oral PrEP after starting the injectable. How does that relate to persons who miss their injectable medication medical appointments, wanting to use the oral form to bridge the injectable medication until they can get into the clinic? Dawn, can you tackle that one again?
Again, what's recommended is that you take oral Kabategravir. I suppose if for some reason you didn't have access to that, but had access to tenofovir-based pills, you could do that. But the recommendation is really to bridge with the same agent, with oral Kabategravir, because what you're trying to do is maintain the level of Kabategravir at a therapeutic level. So rather than switch to a different agent, it would be better to take Kabategravir.
Thank you. I've had several people living with HIV that are on the new combo injectable treatment, but decided to switch back to oral medications because they reported the injection is painful. Do we anticipate this may be the same with injectable PrEP? And I'll start and say, I think that that injection site issues tended to be one of the most common things reported. And so there may be people who decide that either the schedule of visits or the potential pain of the injection may move them more toward using an oral rather than injection. Dawn, anything to add there?
Yes. Cabenuva is 2 drugs. So it's 2 injections, one of Kabategravir and one of rilpivirine. The rilpivirine is actually more painful than the Kabategravir. And so I think that the issue of severe painful injections resulting in the desire to discontinue is less common in Kabategravir for PrEP than in Cabenuva. It's interesting in the clinical trials that men, in the trials that included men, they reported more injection site reactions than the trials that included women. And we're not really sure why that's the case.
Great, thank you. So Dawn, we've done a really good job. We've cleared the questions and we have 1 minute left. So I think that this is a great space to tell everyone, thank you so much for joining. I hope that we provided you some information to really take that one takeaway, which is that PrEP prescribing is for everybody. So please do consider thinking about PrEP. And the best way to practice doing PrEP is to do it. And so please do look at our guideline. Please talk to folks about PrEP. And then really consider starting it on people. I think the guideline is very clear and makes PrEP provision pretty straightforward from the perspective of integrating it into your day-to-day. And with that, I will thank my co-presenter, Dr. Smith, thank everyone for attending, and the team behind the scenes, Dion, Carolina, and Malika, who worked so hard to make sure that we actually got all of the tech in line and all of everyone in the right place at the right time to be able to have this webinar. So with that, enjoy the rest of your day. The recording will be made available soon, as well as the slides. And thanks again for joining. Thanks, Dr. Smith.